Well, well, well. Look who decided to finally show up.
It's like 2 minutes.
First off, let me just start by saying, how dare you? And we're coming up with some unique crime and punishment for you guys that were late by 1 minute. We thought about having you sing Bohemian Rhapsody in unison. That would be pretty good. I thought that was good, but public humiliation is not my game, so I was thinking maybe I would give the people that were here a test question every minute that you guys were late. Fortunately, you were 0 minutes late, so no test questions got compromised, so good job. Dang. Don't worry, I always give one free answer at the end of my review to the winner of the Kahoot, so just keep that in mind. It's a highly coveted free answer. I can't say more than that. Just wait. Just wait. Anywho, so any questions on stuff we covered last time? We're getting through the geriatrics. We covered in most of the pediatrics. Shh. That free answer is tantalizing. Let's keep their chatter to a minimum. Any questions though from the last time we talked? Fantastic. Everyone's a pediatric expert now, right? Remember the takeaways? You just treat them like little adults and everything works out? No, you don't do that. That's not good. All right. So anyway, so talking about the different ways we were dosing these kids, most of the time we use what type of dosing? What strategy? Weight-based, right? That means how many milligrams per kilogram or mics per kilo, things like that, right? There's body surface area dosing, which is used if you need something a little bit more precise. What's the difference between body surface area in terms of how you calculate it versus like a weight-based dosing? And for the BSA, you're also factoring the patient's height as well, right? Remember, there's a couple of different equations out there for that. You can always just look them up online or on your calculators in like if you have MedCalc or something like that on your phone. But that factors in height. That's why it's a little bit more precise than just using a strict weight-based dosing. But it's more cumbersome, so we don't do it too frequently. I do it a lot for chemotherapy calculations, right? So if we're doing like the kid has leukemia and we're treating them with vincristine, it's like how many ever milligrams per meter squared, right? That's a BSA type of dosing. Most of the time, though, 95 times out of 100 is going to be the weight-based dosing. But getting into drug administration here, one of the big things you'll see is that IV drug administration can be a challenge with pediatric patients. Why do you think that might be the case? They don't like IVs. That can be a traumatic experience. There's a lot of adults that don't like getting stuck with IVs either, as it turns out. What other problems can you run into? Little tiny veins, right? Especially imagine, if you will, well, it's not a pretty picture, but imagine you have, say, just like a 2-kilogram neonate being rolled into the ER in cardiac arrest. Their heart's not beating, they're not perfusing. Imagine how hard it is to get a vein in that sort of situation. Near impossible, right? How do you get around that? Remember, you have alternatives, things like intraosseous administration, things like that. But getting into the actual, once we have the actual IV placed, right? Remember, we have differences between peripheral and central access. What's the difference between those two? Central, where's the central empty out into? Using the vena cava, right? So it's going to be emptying out right by the heart. You go right into the right side of the heart. How about peripheral? What does that mean? Usually in an extremity, right? Usually in a peripheral sort of spot there. So you have to consider the sites of administration for, especially like for neonates, you can actually use some of the veins in the head to get an IV potentially, right? So again, it just depends on the patient population you're dealing with, what you might see there. But you're right, it can be very traumatic, and so sometimes we have to give medications just to chill the kid out enough to where we can actually get the IV placed. So sometimes we have to give them anxiolytics, either orally or intranasally, just to kind of calm them down, so that way we can get the needle placed. We have a lot of drugs we use to help with the IV stick analgesia. We have things like Freezy spray. So you ever take like a can of like compressed air for like cleaning like computer stuff and you spray it too hard and it gets really cold? We have stuff like that we use on the skin to actually numb up the skin, so that way we can get a stick without it hurting so much. So different factors there, which we'll get into at a later time. Other things you want to consider with IV drug administration is just the volume of drug you have to administer, right? So when I say volume of drug, what do I mean? Like how loud it is? Loud medication, soft. No, it's like basically how many mLs I have to administer of a medication. If it's, say, a 2-kilogram neonate and I'm trying to administer 40 mLs of fluid, that's quite a bit of fluid for them. That may be way too much. You have to consider what's the drug concentration. Can I get it more concentrated? Are they fluid restricted? Things like that, which we'll get into more detail on in just a little bit. Also, looking at things like, do they have multiple drugs running at the same time? Sometimes there's incompatibilities between the two. Sometimes drugs will precipitate out in the middle of the line, and that can be a problematic because then you have to get another line set up. And there could be other issues as well. Also think about, these little ones, even getting multiple blood draws for labs can be really difficult. You can actually drop someone's hemoglobin, these neonates' hemoglobin, just from too many lab draws, right? So those are things we have to consider and be more conscientious about when we get our samples, and try to get as many labs off the same sample as we can, right? So a lot of factors that go into this. Normally, you don't want IV drugs for, especially neonates, to be something you just, hang it and then forget it and walk away, right? We need to be very precise when we're administering these drugs to these patients here, because again, if you screw it up and accidentally hang a liter of fluid onto a 1 kilogram neonate, that's not going to be good, right? That's double their body weight essentially, and so you're basically going to be flooding that into them, and kids have died because of that, right? Because they got the volumes wrong and screwed it up. So a lot of times you're going to see that we'll have things in place like pumps, like actual drug pumps that are ensuring that we're getting the right amount of drug, the right volume of drug into the patient at the right speed. Because again, some things given too quickly can be a problem as well, right? Here's an example of a syringe pump that we would set up for a pediatric patient. We do this a lot for smaller volume IV drugs that we're trying to administer. Usually if it's a larger volume, we put them into a bag, and we have different pumps for that. But some of the features I just want to kind of point out here are some of the safety features here. Is that one, notice here that the pump can actually detect the actual diameter of the syringe, so it knows what size it is. So that way it knows how quickly it needs to push the syringe in, the barrel of it in order to get the plunger into the barrel to get the drug out at the specific rate. The thing I want you to kind of note here is that this is all computerized. So that way we have a library set up here in order to make sure that whoever's programming it doesn't do it incorrectly, right? So that way we have certain concentrations built in that nurses can't go outside of. We have certain doses built in, certain rates built in. So that way they can't go and give something too quickly, too much of something based on the patient's weight. We call that guardrails, and we keep them on specific guardrails, and they're within the library. Well, what happens when they go outside of guardrails? Hey, well, this drug's not, I can't program this drug in, it's not working right. Let me just go outside of this and just free program it. Is that a problem? Yes, you can see lots of errors that way, right? When you go outside of the standards, you run into issues. Perhaps when you get errors like this, you should ask the question, why is this erroring? Maybe I should call somebody to try to figure it out, because when you go outside of that, that's when a lot of big errors can actually happen there. Try to tell people, just like you don't want your roller coaster to go off its guardrails, you probably don't want your nurses going off their guardrails either, because you can see some patient issues that can develop from that. So again, a lot of safety features built into pediatrics because they are such a at-risk population, right? Now, oral administration becomes a little bit more challenging when dealing with children. So for instance, why do you think oral administration of drugs could be challenging? Yeah, if you'd like to wear medications, this is a good way to do it, right? The little extra saliva mixed in. So actual patient compliance can be really difficult. Like, so for instance, if I'm trying to give a drug to my 1.5-year-old, she kind of doesn't really care so much. She kind of takes it, whatever. She squirms a little bit, no big deal. Trying to give it to my 3-year-old is essentially like trying to, I don't know, you ever see like Silence of the Lambs? She's like walking through the insane asylum, and the guy jumping out, and it's kind of like that. Like, it's very dangerous and very difficult to administer that. I have a whole new respect for pediatric nurses. They are just miracle workers the way they can give some of these meds. But point being is some of the things you have to consider as well is can we give tablets and capsules to many children? Frequently not, right? They can't really tolerate and swallow those. Even some adults have some issues with that, some hang-ups with swallowing tablets. And so we have to use a lot of liquid medications, right? So to get medications into a liquid, oftentimes we have to put a lot of inactive ingredients along with that. So for instance, some drugs have to go into an alcohol base just to put them into solution, right? So how do you think that tastes for the kid? It tastes really awful and it's gross, and they don't like it and they want to spit it out at you. So that can be a really big problem, right? Other drugs, in order to make them a little bit more palatable to the patient, what do we do with them? What do we add into it? A lot of sugar, right? Just like Mary Poppins said, a little bit of sugar helps the medicine go down. Well, we do the same thing, and it makes our drugs taste a little bit better, and it helps them to try to tolerate it a little bit better. So I remember when I was first, I actually opened up Nemours in 2012. I was there trying to set up the pharmacy, a couple months before we actually opened, and one of the things we said was, okay, we need Tylenol, obviously, like a hospital needs Tylenol. So we ordered a bunch of this Tylenol, and we got the cheapest ones we could find, because again, we're trying to save costs and be, responsible with our funding. And it came in, and it was this red cherry flavor. Does anyone like red cherry flavor? That's kind of gross, right? Kids think the same thing, apparently. And we almost had a revolt with our nurses, and they said, you will not be using this stuff in this hospital. We will walk out of this place if you try to. Not literally, but they were basically being very forceful about it. And so I said, okay, well, what do you want? I get the grape stuff, obviously. And it was like twice as expensive, but we got the grape stuff, and that's still what we use to this day. So again, palatability is a huge issue with this stuff, right? Texture can be a big deal. A lot of it matters. Why might having all that sugar and other inactive ingredients in those drugs be a problem, you think? Maybe a food interaction, perhaps, or if they have an allergy to one of the dyes that's in it, right? That purple color, the grape flavor, has to have some red dye in it. Some kids have red dye allergies, right? What if it's a diabetic patient, extra sugar? We actually have some kids. Anyone ever heard of a ketogenic diet? Most people have heard of keto diets, right? What is the kind of cornerstone of a keto diet? No carbs, a lot of protein, a lot of fat, right? Essentially. Why do we incorporate small amount of carbs? To induce ketosis, right? What is ketosis essentially? Breaking down fatty acids, right? So instead of using blood sugar, you're trying to use alternative sources, right? Hopefully not amino acids, but certainly fatty acids and things like that, right? So when you're metabolizing those fatty acids, they turn into ketones and other acids. And so it puts his body in this mild state of metabolic acidosis. The reason why we use this clinically is because we have certain kids who have a seizure disorder that can be very difficult to treat. They can have dozens of seizures in a week. In order to treat that by putting them in a slightly acidotic state, you end up increasing that seizure threshold. I always have a hard time saying that. But you increase that threshold to make it more difficult for them to have a seizure, okay? It's all well and good. So this kid's on a ketogenic diet, they're in ketosis, everything's looking pretty good. They come into the hospital and they say, okay, well, the kid's got a fever, let's give him Tylenol. So we give him that Tylenol that has sugar in it, and guess what? Knocks them out of ketosis, pH comes back up, and then what happens? They can have a seizure, right? So this can be very challenging in order to make sure that we're giving the right dosage forms to the right patients there. And if you ever see someone with a dextrose allergy, it may sound silly because like, who can be allergic to dextrose? Well, oftentimes we'll flag that in their chart that way, so that way we know, and we can ask the question, hey, are you on a ketogenic diet? Because if that's the case, then we have to do different dosage forms. Sometimes we'll take tablets and crush them up into water, and then it's less palatable, but again, it doesn't have the sugar in there. Different things to get around that. So these are all things we're considering. One of the biggest ones, though, is the measuring devices. Now, traditionally, how do we measure out oral medication, oral liquids? Or a teaspoon, right? What else? Sometimes you get like a little cup. Nowadays, we get a lot of oral syringes, which is nice, right? So what's the problem with using teaspoons and tablespoons? Yeah, what's a teaspoon? That's a great question. What is a teaspoon? How much volume is a teaspoon? 5 mLs. A teaspoon is 5 mLs. A tablespoon is how much? 15 mLs. Okay. Now, are all spoons created equally? If I go to Walmart and I buy a spoon from there, and then I go to IKEA and I get a Swedish spoon, they can have vastly different volumes, right? So not all spoons are created equal, and thus not all doses would be created equal. But that was the mantra for a good long time. They say, hey, we're dosing 2 teaspoons every 6 hours, right? So that was kind of an issue there because some patients would get 12 mLs, some people may get 8 mLs. It just depended on what the measuring device was. So now a lot of times you'll find that oral liquids will come with like a little tiny cup with like a little dosing demarcations on there, 5 mLs, 10 mLs, etc. And then the most accurate way to do it would be what? The syringe, right? That's the most accurate way you can get within, say within 1/10 of an ml or something like that, which is generally pretty good for our purposes. And in fact, I was giving medicine to one of my children one time, and it came with one of those little dosing cups, and I said, I want to see how accurate these things are. So I filled up to the 5 ml mark, and I drew it up in the syringe. I ended up like 6 mLs. I was like, well, this thing's not very good. But again, that's what we used for a while. So some kids may be getting under or overdose depending on the measuring device. So that's an important consideration. The dosing syringes are always going to be the most important ones to go with, and that's what we use as a standard in most pediatric hospitals and really anywhere you deal with pediatrics. Okay. Anyway, so when you're prescribing meds for these patients, make sure you always get a current weight. Oftentimes the kids come into the ER and be like, hey, what's the weight of the patient? And they'll be like, it's like 10 pounds. When was that? Last month at their pediatrician's visit. Is that the same weight as now? Not always, right? So these are things you got to consider. Try to get an up-to-date weight whenever you can. Always check with your available references, right? If you notice when you're looking up things like an up-to-date and you look for a drug, oftentimes there's different libraries you'll fall into. There's LexiComp, right, for most of the drugs. There's also a pediatric version of that. And you want to make sure you're looking for specific information for pediatrics in order to make sure that it is appropriate for them. Because we talked about all the kinetic differences that occur. This is how we factor in for that. And then obviously for education, with your patients, always consider counseling at the level of your patient. For a 3-year-old, is there going to be a lot of patient education on how to give their meds? No, but for a 16-year-old, certainly, and they want to be taking a part in their health, and so you want to try to communicate with them on their level. Again, sometimes talking to the parents, are they always going to be upstanding individuals, good medical knowledge, and now sometimes they might have the education level of the 16-year-old, right, or less. And so in those cases there, you have to make sure you're talking on their level to make sure they get the right amount, okay? So coming up now we have drug dosing calculations. So you will not have a calculator on your test. However, the math that I put on the test will be able to be done with using your noodle and using your scratch paper. So can you multiply by 5 and 10 and divide by 2 and things like that? This is the simple stuff you should be able to do for testing purposes, okay? We're going to walk through all these tests. Now, the thing I'll note with this is that this is simple stuff for the most part. However, it does seem daunting at first. I will give you a few tips to help get through this. But the important thing is to remember is to always keep your units straight and do the same process every single time, and you'll always get the right answers, okay? This is easy stuff, but you have to do it a lot to have it kind of come a second nature to you, okay? So anyways, let's walk through and look how we would dose these individuals. And this is important because this is going to be your prescription assignment, essentially. One of those questions is about dosing an antibiotic for a child, right? So once you have this portion of the class, then you can go on and do your prescription assignment, okay? I'll have some more talk about prescriptions later, but then basically follow the rubric and you should be able to get most of the stuff done. Anywho, so let's look at the case here. We have a 15-kilo child. Now, should I be using pounds or kilos? Kilos, right? We're going metric for most of the stuff here. How do you convert from pounds to kilos? Divide by 2.2. It's a good number to remember. Divide by 2.2 to convert into kilos. Because most parents, what are they going to tell you when they say their kid's weight? They're going to say pounds, right? So just get used to using kilos, all right? So they're going to get amoxicillin. And what type of drug that is? Antibiotic. And what family it fits into? Penicillin, right? Absolutely. You guys know. You guys already know farm. It's great. So this is going to be for an acute otitis media, right? So have an ear infection. They're going to be getting 90 milligrams per kilogram divided twice a day, right? BIDs twice a day. What's 3 times a day? TID 4 times a day. QID, how about 1 time a day? Don't say QD. That's actually a big no-no. You'll see that on the prescription assignment. Q daily, Q day, daily. Any of those are fine. QD is a unapproved acronym or abbreviation. We do not use those anymore because it could be mistaken for other stuff. We'll talk about that later. Anywho. Getting back to it, so we have our amoxicillin suspension, 400 milligrams per 5 mLs. Now, why does it say per 5 mLs? It's a teaspoon, right? And again, that's how people dose medication for a good long time, was 1 teaspoon, 2 teaspoons, etc. So you'll see frequently they get expressed in that per 5 ml. That's really just sort of an anachronism, sort of this is just what we have done forever, and no one's bothered to change it, which is unfortunate. So, question being is how much should this patient receive per dose? Anyone got the answer yet? I'm just kidding. We're going to go through it together, okay? So, first thing we should figure out is that, well, how much should this patient actually receive per dose? I'm going to do this one actually all the way through the actual PowerPoint itself, and then the follow-up ones we're going to do it together, right? So, I'll have to use my calculator too to come up with the answers. So, we have this patient and we say, okay, well, how do we come up with the dose that they should receive per day in the first place? How do we figure that out? Well, I know the dose is 90 milligrams per kilogram per day, so I multiply that by the weight of the patient, right? I want to figure out what the total daily dose is going to be first, okay? So I take 90 multiplied by 15, right? And this is free participation, so you can shout out answers. It's totally fine, right? This is a safe environment. There are a lot of wrong answers, but we'll talk about it. It's okay. You don't have to feel judged by having a wrong answer. It's fine. It's your first time doing this. So anyway, so you take 90 times 15. What do we end up getting from that? We get 1350 a day. So they should be receiving 1,350 milligrams of amoxicillin per day. Are you done at this point? No, right? You wish, right? If only it was so simple. Well, now let's figure out what they're going to get per dose. How do you figure that out? Divided by 2, right? Because again, it says divided BID, so you know it's divided into twice daily, so you divide by 2. So the total dose should be 675 milligrams per dose. Remember, we're keeping our units together. Be very specific when you're keeping your units there because it's easy to get lost if you don't use your units appropriately, okay? So now we know what the dose is going to be per administration. So let's go ahead and go from there. So the question is, well, okay, well, they get 675 per dose, but do you think you can tell that to a parent that, here, give 675 milligrams to this patient there? Not really, right? Can you count on the parents to be able to convert that over to mLs? Some of them may be able to. A lot of them will not be able to. So you need to do this for them. And when you write out your prescriptions for these liquids, you need to write out the volume or the mLs that you need to administer to that patient, okay? So anyways, we know our dose is 675 per dose. We know our concentration for our drug is 400 milligrams per 5 mLs. Was that super useful to know it's per 5 mLs? What would be an easier way to work with it? Per ml, right? Per 1 ml. So I get rid of that 5, just divide it out. So if you ever see that per 5 ml, per 10 ml, just get rid of it, right? Divide it out. Now I know my amoxicillin is coming in at 80 milligram per ml concentration, okay? So now what do? I divide. So I take my dose. They should be getting the amount of milligrams per dose they're receiving, 675, divided by 80 milligrams per ml. Now what cancels out here? The milligrams cancels out, right? So milligrams cancel out, and I'm left over with 8.4 mLs per dose. Now on the prescription, you could write, take amoxicillin, 8.4 mLs by mouth. Otherwise, how do you abbreviate that? PO/BID. Okay, and that's it. You're done at that point. Every calculation from here on out is essentially going to be doing the same exact thing. It's figuring out the concentration, figuring out how much they need to get per dose, and then converting it to the ml volume they need to receive. Simple, right? I can tell the weather is starting to mimic how you guys feel about this stuff. It's okay. We'll get through it. Let's say, and I'm going to be doing this with you, so I'm not looking at my Facebook or anything. I'm looking up my calculator, right? You guys can see it. Calculator. Let's do a different calculation here. Let's say we have an 18 kilo patient that needs ranitidine. Anyone know what that is? Zantac, absolutely. Yeah, it's an over-the-counter medication you can use for GERD symptoms. It blocks. Anyone know what it blocks? H2. What's H? Heroin? No, histamine. It's a histamine 2 receptor blocker, right? So we'll talk about histamine 1 receptor blockers later, but histamine 2, this is used for GERD symptoms. Basically stops acid production, tries to slow it down. Let's say this dose is going to be given at 4 milligrams per kilogram per day divided BID. And ranitidine comes in a syrup, and it is 15 milligrams per ml. So the question is, how much should they receive per dose? Now, for your purposes for review, I'm going to try to draw out some of these numbers here. However, keep in mind I'm left-handed. I'm also using a mouse with my right hand, so it's going to be slightly illegible, but you should be able to follow along with me, correct? I sure hope so. Anyways, let's do this. So what is the first step here? Well, yeah, so let's figure out what their total daily dose should be, right? So how do I figure that out? What should that be? Multiply their weight by. Okay. So yeah, so how many ever milligrams per kilogram per day they should be receiving? So I'm going to take 18 kilograms, and again, please don't laugh. And I'm going to multiply that by what? 4 milligrams per kilogram per day. Now we'll be here all day long if I write out every single unit, but I'm going to say it, so keep along with me with this, okay? So I'm going to take 18 kilograms times 4 milligrams per kilogram per day, which should equal out to be 18 times 4, 72. So their total daily dose is going to be 72 milligrams, right? 72 milligrams. Now what do I do from here? So I want to go ahead and divide that by 2 because it says divided BID. So I can divide that by 2, right? And what is that? So I should be getting 36 divided by 2 equals 36 milligrams per dose. We're divided by 2. It was per day, but now we divide it by 2 because they're getting it twice daily. Okay, so they should be getting 36 milligrams per dose. Now what do?
Divided by rate.
Right, so now I'm taking this milligram amount, right? So they're getting milligrams per dose. Now I need to figure out how much volume that's going to be, right? What's the ml amount? So I'm going to take that 36, and what I'm going to do with that? I'm going to divide by 15 milligrams per ml, right? I'm sorry, scratch it out. 15, and what should I get? 2.4 mLs per what? MLs per dose. You would say, take ranitidine syrup. You want to put your concentration in there to 15 milligrams per ml. Take 2.4 mLs PO. So that's it. Twice daily, BID, either of those are fine. Okay? Everyone with me so far? Would you like to complicate it further? Yes, absolutely. That's the right answer. All right, let's do this. So now we're going to be dosing a drug. Anyone heard of Bactrim before, or Septra? What do you use that for? UTIs, cellulitis. We use it for a lot of different, it's kind of a broad spectrum antibiotic. We use it for a lot of different things here. It's a combination drug, actually, of 2 drugs called trimethoprim and sulfamethoxazole. Okay, so it's a combo drug we're using for cellulitis for a 12 kilo patient. And the drug is being dosed at 4 milligrams TMP per kilo per dose BID. And here's our suspension here. Sulfamethoxazole 200 milligrams, trimethoprim 40 milligrams per 5. How much did the patient get? You're like, oh boy. Oh boy. All right, so how do we do this? What's the first thing we need to figure out? Well, what are we actually dosing the drug based off of? It says 4 milligrams TMP per kilo per dose. What does that mean? That's an abbreviation for trimethoprim. Keep in mind that when you receive that suspension, that the sulfamethoxazole and trimethoprim are in a fixed ratio, right? So as long as you're dosing it based off of one of the drugs, you're sure to get the right ratio of the other drug as well. So you don't only have to worry about both of them. Just worry about the one that they will dose it off of. And as a standard, Bactrim doses it off the trimethoprim, right? You don't have to know that specific fact of the test, but just know that's generally what we do. So we're basing off the trimethoprim. And so we can now solve our problem here. So the question is, well, how much should they be getting? Okay, so we're going to take our, what's the first step then? So we take our weight, which is 12 kilos, right? Multiplied by 4 milligrams TMP per kilo per dose. Okay, what does that equal out to be? 12 times 4, right? 48. 48 milligrams, right, of TMP. Now what do? Do I divide by 2? Here's where it gets tricky, right? It says TMP per kilo per dose. So do I need to divide by 2? No, I already have it in per dose. This is a very easy medical error to make, right? Make sure when you're reading this stuff, it says milligrams per kilo per day divided whatever. Or if it says per dose, then you don't have to do the division, okay? Be very careful with this stuff because you misread it. You can end up double dosing your patient in this case, or you may be doing only half the dose you should be giving if you were to not divide when you're supposed to, right? Keep that in mind. So it's a little food for thought. So anyway, so I don't have to divide by 2. I already know it's 48 milligrams per dose here. So now what do I do? Yeah, so let me go ahead and convert my Bactrim into the per ml concentration of trimethoprim. So again, this 200 milligrams, I don't even really care about, right? I'm not worried about this one here. But I do worry about the 40 milligrams per 5. So what's this concentration per ml? Which is 8, right? So 8 milligrams per ml. So then I would take this 48 and do what with it? This is 48 milligrams of trimethoprim per dose. Divide that by 8 milligrams trimethoprim per ml. And what do we get? 48 divided by 8, you get 6 mLs, right? So then you would say, we're going to dose this patient with Bactrim suspension. We're going to do 6 mLs PO BID, right? Good. It gets the same thing over and over and over again. It's just a matter of making sure you're kind of doing the step-by-step and getting to the right answer. One of the big things you learn about medicine is that everything needs to be done in a very algorithmic, sort of the same way, do it every single time. What did they told you about doing your physical exam? Do a systematic approach, do it the same way every single time, and you're guaranteed to not miss something, right? The same thing goes for drug dosing as well. Do the same thing every time, and you should be good, okay? Everyone with me so far? Is anyone completely lost? That's good. This is a lot less than what I normally see. That's good. Almost every hand, but now it's 0 hands, so I must be improving. So let's go the other way, right? You guys aren't even laughing anymore, so minds are steaming. It's okay. Let's do it the flip side. Let's kind of do it the opposite way now. So let's say, for instance, and this is a frequent thing you'll see, you'll have a patient who will come in with their parent to the ER, and they say, oh, they're complaining of fever. I gave them Tylenol. And you ask, well, how much Tylenol did you give? And they'll tell you, and then you need to figure out, well, is that appropriate for the patient's weight? Sometimes they don't give enough. Sometimes they give too much. And you can try to figure that out. Because again, if they come in, they're still febrile, but they received a total, a regular dose of Tylenol, maybe you don't want to double up. Or maybe they gave too little, you want to go ahead and supplement that with extra. So let's figure out, let's say we have a mom bringing in this 20-kilogram child, and she's been given 2 teaspoons of acetaminophen 4 times a day for fever. And we know, and you'll learn, that the usual dose is around 15 mg per kilo per dose. Acetaminophen comes as a suspension. It's 160 milligrams per 5 mLs. The question is this child being dosed appropriately? Right off the bat, what do you think? No clue, right? That's good. We can start and work through this, and we'll find out together. Okay. So what do you need to do first? Find out how much the patient's actually receiving. Good. So how much volume has the patient been receiving?
8 teaspoons.
So in this case here, that's actually nice is because my normal dosing is per dose. I actually don't need to figure out how much they're receiving per day, right? So because they're getting 4 times a day, it's really kind of extra information we don't really need here. We just want to make sure that every single dose they're getting is appropriate, okay? So per dose they're getting is appropriate. So how much are they getting per dose? 2 teaspoons, right? Which is how much volume? 10 mLs. We'll assume she has a perfectly calibrated metric spoon that's able to perfectly get 10 mLs. Okay, so we're going to say 10 mLs here, right? So we're going to convert that over. We'll say, did you get it from IKEA? And she'll say, yeah, and then, I don't know. Anyway, they use metric system over there, so. Actually, I don't know if that's the right language or not. That could be totally off. It might have been German. Anywho, so looking at this, so the patient's getting 10 mLs. Okay, so we want to figure out, well, how much is that 10 mLs in milligrams of acetaminophen? What do? Well, we got to figure out initially what our concentration of acetaminophen is per ml, right? So we take this 160 by 5, and what does that turn into? This is 32 milligrams per ml, okay? Milligrams per ml. Remember that for our purposes here. Okay, so the patient's receiving 10 mLs. They're getting 32 milligrams per ml of acetaminophen. So what is their dose they're receiving? They're getting 320 milligrams per dose, right? So the question, is that appropriate? Well, let's figure out how much the patient's receiving in milligrams per kilogram. So now what do? Well, I got the milligrams. How do I factor in the kilograms? Divide by the patient's weight. So I divide by 20 here, right? And so what do I get? Oh, just kilograms. So 320 divided by 20 equals 16. So the patient's actually getting 16 milligrams per kilogram per dose. Now, how does that stack up with the actual usual dose? Pretty good, pretty close, right? Within 10%, I'm totally fine with that, right? So if it came out, though, and it was like 8 milligrams per kilo, what would you say? Oh, you're actually underdosing your child. Here, I'm going to give you a supplemental dose, and then from now on, dose it 10 mLs every 6 hours, every whatever, how often you want to do it, right? So I do this very frequently because you as the providers will be writing these orders. It comes across to me as the actual dose and the volume. I have to backtrack it and double check to make sure that's the right amount based off those calculations, right? So this is the double check process. This is how we make sure our holes of Swiss cheese don't line up, right? And if this is wrong, I can call you up and be like, hey, wait a second, this doesn't look like the right mgs per kilo amount. Like, you want to change that? That's why we'll talk it over. You see how that works? So again, it works both directions in this case here. You can double check your dose, or you can actually just come up with a dose like we were in the last 2 slides. Okay, so has everyone got that? Practice, practice, practice. You can look up oral liquid medications through up to date. You can search for, and again, I'll give you some good ones to use, things like ondansetron or Zofran. That's a good one to look up the dosing for because that's one we use frequently for kids. But just come up with like random weighted kids. Come up with you have the drugs there with their concentration. Just practice it out, right? And if you have any questions, obviously, always email me. Always come by, talk to me. I'm more than happy to walk you through this stuff. Another big topic I want you to know about, and again, the more you can do this stuff and do it kind of cold when you go on rotations, the more of a rock star you look like. Because every student, whether nursing, MD, anyone, like, they're always going to have trouble with this stuff. But if you can do it, because you'll be doing it from now until you basically go on rotations, you're going to be rock stars at this. Okay. Another big topic that some people have issues with is going to be IV fluid administration for children. And actually, the nice thing about this stuff, these calculations, they'll work for adults too. But let's talk about them in terms of pediatrics here. So when you administer fluid intravenously, why do we give people IV fluids? Straight to the system. We do it if they're dehydrated. It helps to keep with their maintenance losses of fluid, things like that. So when you administer fluids, frequently, imagine they come into the ER, they've been vomiting, they may have a lot of diarrhea. You want to kind of tank them back up, right? That's why my term you use. So you tank them back up with lots of fluids, and you get them back to kind of where their baseline should be, right? Remember how we talked about loading doses for medications? This is kind of like that, right? When you give a bolus, a fluid order, this is what we're going to be doing here. A standard dose for fluid boluses is 20 mLs per kilo. Just memorize that number because you're going to be using it from here on until the end of your days, right? 20 mLs per kilo. If you had a patient who you're worried about maybe giving too much fluids to, maybe they're fluid restricted or they have kidney disease, maybe you go less than that, maybe 10 mLs per kilo. But for the most part, 20 mLs per kilo is going to be pretty good for your patients, okay? Now, I can give them a fluid bolus and get them tanked back up, but how do I maintain them at their hydration status? Do I like put a cork in their urethra and say, don't pee anymore? Don't lose any more fluids? No, they're still going to have losses, right? They're still going to urinate, they're still going to sweat, they're still going to breathe, they're still going to lose fluid. That's why we give maintenance fluids. Just like we give maintenance doses of medications, this keeps them at a baseline, right? It helps to prevent them from getting dehydrated or getting fluid overloaded. So the way we figure out their maintenance IV fluid rate is the 4-2-1 rule. Okay, this one's a little bit not intuitive at first, but we'll work through it a couple times with some examples here, and you'll see what we're talking about. The 4-2-1 rule basically says that to get the maintenance fluid rate for your patients in mLs per hour, you follow this handy rule set here. Now notice here, why is it mLs per hour for the maintenance rate, but not for the fluid bolus? The fluid bolus is one of those intermittent doses. It's a one and done kind of thing. You give it, done 30 minutes, 10 minutes, whatever the case may be. However, the maintenance fluids are continuous, right? These are for maintenance. They're going to be receiving this continuously. You need to know what rate they're getting per hour, okay? Again, these are very common orders you're going to be writing for most patients you're admitting. If you work for surgery, you work for intensive care, anywhere you work, you're probably going to be doing this. So the 4-2-1 rule, basically, their maintenance rate in mLs per hour for the first 10 kilograms of their weight is going to be 4 mLs per kilo per hour. For the second 10 kilograms, yes ma'am. So say you have someone who weighs 30 kilograms, that first 10 that you're dealing with, you're going to get 4 mLs per kilo per hour. We'll walk you through the examples, and we'll wrap it around to it. You'll see what I'm talking about. For the second 10 kilos, the next 10 kilos of their weight, you're going to be doing 2 mLs per kilo per hour. And then for every subsequent kilogram, they get 1 mL per kilo per hour. 4-2-1 rule. Okay, so let's work through some examples and see what I'm talking about. Let's say, for instance, we're going to do the bolus rates and we're going to do the maintenance rates for these kids here. We have an 8 kilogram infant. So the bolus dose of fluids you would order for this patient, let's say we're going to use normal saline, will be how much? The 8 kilograms times 20 mLs per kilo. The kilos cancel out, and what do you get? Right, so this patient will be getting 160 mLs as a fluid bolus, right? Okay, what about their maintenance rate? Okay, well this kid is only 8 kilograms. They're not even 10 kilograms, right? So we only have to worry about the 4 part of the 4-2-1 rule, right? Because they haven't even gone past the first 10 kilos. So for that kid, basically you're going to be getting 8 kilograms times what? 4 mLs per kilo per hour. The kilos cancel out and turns into how much?
2 milliliters per hour.
Right, so this kid's going to be getting 32 mLs per hour. You know how much volume like a 32 mLs is? How much is a fluid ounce? 30 mLs is 1 ounce. 16 ounces to a cup, or 8 ounces to a cup, 16 to a pint. You guys are thinking in beer terms. It's okay, I don't blame you. 30 mLs for 1 fluid ounce. Okay. How much is a shot of
6 ounces.
of your 6 ounces? That's a huge. Someone's gone to Senior Frogs a few too many times. Methinks. Usually a shot, if you think like a shot of alcohol, is normally 1.5 ounces, 45 mLs, right? So again, this kid's not really getting that much volume. It's only basically 1 ounce an hour of fluid they're actually getting there, right? I'm trying to equate the volumes, because you might think 32 mLs, what the heck does that mean? But actually think about the volumes you may be dealing with in the real world. But again, you guys don't do that drinking sort of thing, but you can Google pictures, right, if you need to. Yeah. Definitely don't go anywhere tonight or tomorrow night to figure it out, right? You don't need to. Let's think about, though, let's say we have a 1,200 gram neonate. How many kilograms is that? Good. Everyone can do their conversions, right? It's good to be able to convert from milligrams to grams to kilos, etc. So this would be a 1.2 kilo patient, right? So what would their fluid bolus dose be?
4 milliliters.
So 1.2 times 20, which is 24 mLs, right? Look how small of a volume that is. They only get an ounce, and that's their fluid bolus. It's meant to replete their intravascular status. Like, it's not much fluid, right? These are very small children you're dealing with there. What would be the maintenance rate for this child? Again, we're not passing even the first part of that 4-2-1 rule. So really, you just have to do that 1.2 times 4 mLs per kilo per hour. So what does that turn into? 4.8, let's do 1.2 times 4, and you get 4.8. Very good. So 4.8 mLs per hour. Not even a teaspoon per hour that patient's getting, right? Very small volumes you're dealing with. So imagine I'm trying to give 10 mLs of drug to this patient. It's a lot of fluid, right? These are things you have to be careful with. It would be almost 2 hours worth of fluid for that patient there. Just thing to think about. Anywho, okay, so let's go with the heavier child. Let's go with someone who is 45 kilograms. Let's figure out how much volume we're going to be giving them, right? So 45 kilos for a fluid bolus would be how much? 45 times 20 is what? 900. Fantastic. The patient's going to be 900 mLs. Now, would it be the end of the world if I gave them a whole liter? How much is a liter? 1,000 mLs. Probably not, right? It's probably not going to hurt the patient. It'd be fine to round up that sort of thing there. But let's say for strictness sake, we're going to go with 900 mLs. That's our fluid bolus. Again, I'm not going to put like, very similar numbers on the test. Like it'll be very easy things where if you skip this step, that's going to be one of the wrong answers. And if you got the right answer, it'll be very clear that that's the right answer. So again, don't worry. I'm not trying to trick you on the test. You may feel like you've been tricked. I will not have intentionally done so. Now let's try to figure out what the actual maintenance rate for this for this patient would be. So for the first 10 kilos of this patient's weight, it's going to be 4 mLs per kilo per hour. So 4 times 10 is going to be what? So good. So the patient, for the first 10 kilos of their weight, they're going to be getting 40 mLs per hour, right? Now I'm going to add that to the next 10 kilos of the patient's weight and multiply that by 2. So 2 mLs per kilo per hour times 10, good, and what equals? 2 times 10 is 20, right? So 20 mLs per hour, okay? And then now what do? I take every last kilo I've left over, which for this case I have what? How much left over? 25 kilograms left over because I used up 20 already. I have 25 left over, and I multiply that by 1, right? So then that would equal 25 mLs. So basically I just add these up. So I have 40 plus 20 plus 25 equals 85 mLs an hour, right? That's a horrible 8, but they get mLs per hour, right? Please don't put this on my eval. Bad handwriting. Should go back to kindergarten. No. That's really bad. There we go. Correct it. Yes, ma'am.
So the first number we're calculating is the fluid bolus amount that we're giving, and then the next one is what we're going to give per hour for dependent on that.
For the maintenance rate, yes.
For the maintenance.
Yes.
Okay.
So you get your fluid bolus, and then you follow it up with a maintenance rate typically.
Okay.
Yep. Does that make sense now between the first and the second 10 kilos and then all the subsequent kilos? A little bit more sense?
Yeah.
Why is the second one 4.8? I thought it would be the 24 they divided by 4.
So the bolus dose is going to be completely separate from the maintenance rate, right? So the bolus is only calculated off of the weight of the patient. So it's 20 mLs per kilo, multiply that by the patient's weight, and now you got your fluid bolus. That is one order you'd write for. You'd say normal saline, 24 mLs IV once, right? Then for the follow-up, for the maintenance rate, that's when the 4-2-1 rule kicks in. So you just say 1.2 times that 4 mLs per kilo per hour, and now you have your maintenance rate. You'd follow it up by saying, let's do D5 NS, 4.8 mLs per hour IV, right? You know what D5 means? It's 5% dextrose, and NS stands for normal saline, right? So it's a combination of salt and water, basically. Or, I'm sorry, salt and sugar we're giving the patient. That is a normal maintenance fluid. Don't worry, we'll talk about that a lot later. But this is how we come up with the maintenance rate for that stuff. Now let's do 100 kilogram. Oh, yes, ma'am.
So for anyone that's heavier than 20 kilos, wouldn't you always be doing 40 and 20?
Mm-hmm. So that's the thing. After a while, especially if you work in pediatrics or you do this frequently, and you can do the same thing for adults, and you're going to get pretty close to the right answer. You're going to find that it becomes ingrained, right? It's going to become, you just naturally can do this. So like we do a lot of admissions, and I see a lot of these fluid orders come across, and I can just look at the weight and just come up with the maintenance rate pretty quickly and double check it against what the provider wrote for. And again, you'll get very comfortable doing this stuff. But you're absolutely right. Once they're past 20 kilograms, and you just say, okay, well I know they're at least eating 60 mLs an hour, and then you just add up whatever they have over 20 kilograms.
You just add 40, because 20 and 60 difference is 40. You add 40 to the kilograms and then make it at the milliliter dose for the maintenance.
Say it again.
So, because you go, it's basically going to be, it's 60 for the first 2 of the 4 and the 2 total. And then it's going to be, but it takes 20 of the kilograms to get there. So really you can just take the kilogram and then add 40 to it and change the unit. And
Now you're confusing me even.
like you see how 45 kilograms turns into 85?
Mm-hmm.
Well, it's basically you're going down 20 and then you're adding 60. I don't know. It's just
No, because you're going to see there's diminishing returns on that. So if you look at, so say for instance, if you look at the weight of the fluid will come up with for the 100 kilogram patient, there's diminishing returns.
Okay.
So for that first 20 kilos, you're always going to get 60 mLs an hour, and then everything else on top of that is going to be kind of extra, right? So again, you're going to find that for like say 120 kilogram patient, again the difference gets even smaller as the weight goes up. So let's go through and let's do the calculations for the 100 kilogram patient, right? So let's say we have, and again we see, do you see pediatric patients weigh this much? All the time, right? You know, we have a contract with Walt Disney World. Well, if a kid gets injured or they get sick over at Disney, they get transferred over to us. So they have, the wide world of sports. They have a lot of like cheerleading competitions and football competitions. We get these like 17-year-old like linebackers that come in, broke their femur. They're getting fluids too, just like everyone else, and they can weigh this much, no problem. So let's go ahead and do the calculation for this. So for a 100 kilogram teenager, what would their fluid bolus be? So 20 mLs per kilo times 100 equals 2,000, right? So again, you could just give them straight up 2 liters in that case there. Now, some people might be a little more cautious and say just start off with a liter. The thing with fluids, you'll learn, you can always give more. You can't really take it away once you put it in, right? It's kind of hard to do that, whether either you diurese them with drugs or you put them on dialysis. It's hard to do. You can always give more fluids if you need to. But theoretically, this patient can take 2 liters of fluid, no problem, okay? Now, let's go ahead and figure out what their maintenance rate would be for this patient here, okay? So for the first 10 kilos of their weight, would be how much? Right, so 4 times 10 would be 40 mLs per hour, right? 40 plus the next 10 kilos would be 10 times 2, which would be 20 mLs per hour, okay? Plus, how much do we have left over now? We have 80 mLs, right? So now we have 80 mLs. That's a much better rate. And then what does that turn into? 140 mLs per hour, right? That's not M. There you go. I really apologize. I'm so sorry. Anyway, so basically that patient will be getting 140 mLs per hour. Now, sometimes you might see them write on orders do 2 times maintenance or maybe 1.5 times maintenance. Basically, this is your starting number, right? So if I wanted to do 2 times maintenance for that patient, I could put them on 280 mLs an hour, and that would be 2 times maintenance, right? But this is just a straight maintenance rate.
So we say per hour, so what's like the time period? Is this like a 24 hours?
So that's a really good question. So the question is, you write an order, you say, let's do D5NS, 140 mLs an hour, IV. That order will run until the sun burns out and the earth is no longer here. No, it basically runs continuously, right? If you put a stop time on it, if you say I want it for 3 hours, then it will run for 3 hours, right? But unless you specify time, it'll assume it's just going to run forever, right? So very frequently you'll write orders that will say, hey, start maintenance fluids at this rate, and maybe you come see the patient the next day and say, okay, well, they have good PO intake, they probably don't need the IV anymore, then you can discontinue it. Right. So again, if you don't know what the kind of course they're going to take, you don't know how long they're going to need the IV fluids, you just leave it running continuously, and then you can DC it when you need to. Okay. But if you put a specific rate on there for a period of time, then it will cut off at that time, assuming the nurse goes back and actually turns it off. Right. Yes, ma'am.
Does the maintenance dose start immediately after the bolus dose, or is there a waiting period?
That's up to you, right? So you as a provider can order that, right? So in some cases you may find, say for instance you're working for the hospitalist group. In the hospital, you're admitting a patient onto the med surg floor. They may have gotten their boluses in the ER already, and then you just want to start them on the maintenance rate. That's pretty frequent. We'd see that. If you're just in the ER, maybe you only want to write for the boluses. You'll let the admitting person do the maintenance rates. You're working in the ICU, maybe they're on a maintenance rate, and you notice their blood pressure is starting to get a little marginal. Maybe you want to kind of tank them back up a little bit. You can write for a bolus in the middle of that. So any way you want to do it can be done, for sure. So everyone with me so far? I hope so. Anyway, so practice with that stuff. Just make up like random weight children, and you can come up with your own rates. Give them to your friends. You can double check each other. If there's any discrepancies, always come back and you can ask me, and we'll walk you through it. There's other ways to come up with maintenance rates for patients. If you ever see like a holiday Seeger method, it essentially does the same thing, but it does it per day. It's not really as actionable as getting a nice ml per hour amount there, but it basically comes up with the same answer, within a few mLs or so. So, any questions on that so far? Okay, I'm going to let your little minds kind of chill out. Actually, no, wait, I have one more calculation. Sorry, I'll give you a break in just 1 minute. Let me blow your minds a little bit more, and then I'll let you go. So one other thing you'll frequently see is that medications will be expressed not necessarily milligrams per ml, but they'll say a percentage. They'll say 1% lidocaine, or they'll be, say, 0.25% bupivacaine, right? Now, the question is, well, what does that turn into in terms of concentration? Because you as a provider may want to know, well, how much could I give a patient potentially, right? What's the max dose that I could administer? So let's say you're working in the ER and you have a patient come in with a large laceration. You want to numb up the area so you can suture. You want to use lidocaine. The question is, well, how much can you give? And that patient could receive a maximum of 5 milligrams per kilogram at one time. Any more than that, then you start to worry about toxicity. So the question is, well, if I have a 1% lidocaine solution, how much can I give that patient? You're going to look at that and you're like, well, I have no idea what 1% really means. So I'll give you a handy tip. Traditionally, what it means is basically it means how many ever grams you would have in a 100 ml solution. Don't worry about that, right? We're not too worried about that. Well, you can do a handy tip, and this works for anything it gets expressed as a percentage, is you'll take that 1%, you take that little decimal place there, you're going to move a 1 over to the right. Okay? And that is now your milligram per ml concentration. So 1% lidocaine is really lidocaine 10 milligrams per ml. What if I had 0.25% bupivacaine? You have to know what the drug is. It would be 2.5 milligrams per ml. A minute ago, I mentioned dextrose 5%. How many milligrams per ml is that of dextrose? 50, right? It works for everything, right? I'd never learned this throughout pharmacy school. It wasn't until I was in fellowship that I learned this. So again, this would have saved me I don't know how many hours of calculations. But this is a handy tip to remember when you're doing this stuff. So now that we have a concentration that's a little bit more easy to work with, we know it's 10 milligrams per ml. The question is, how much could this patient get? So how much is the max dose this patient can get? It's 5 mg per kilo times their weight, right? You got to figure out how much it is based off their weight. So we got 24 kilos times 5, right? What does that turn into? 120. Okay, so 120 milligrams they can get. I didn't do this one, so I'm trusting you guys on your calculations.
That's right.
Okay, so it's 120 milligrams. The nice thing about crowdsourcing calculations, usually come with at least one right answer. So we have 120 milligrams that we can give this patient in total before we start to worry about toxicity. How much in volume can I administer into that laceration? Well, I know it's 10 milligrams per ml, so I can just divide this by 10, and what do I get? 12 mLs. Again, I only mention this because this is a frequent thing. I would get questions. I'd have, suture techs and things like that come up like, how much lidocaine can I give this patient? They weigh this much. You can figure it out, right? Based off the concentration of lidocaine you're using, based off all that stuff. Okay? Any other questions on that stuff? Okay. Yes, ma'am.
Is the max dose the amount you want to give though?
Not necessarily, but sometimes it's good if you, sometimes you can't just look at something and know how much you're going to need. So at least if you know what your cap is, you can say, okay, well, I know I got this big of a laceration I need to repair. Let me go ahead and make sure I'm using it evenly. If you have a little bit left over, no big deal. But at least you know you don't want to go above that certain amount. Okay, any other questions? If not, let's do a 10-minute break. We'll come back and then continue on to the next section. All right, I saw there is a prescription writing assignment. Can you briefly talk about that? I can briefly talk about that. So you have a prescription writing assignment. It is posted. You should be able to see that there. There should be 2 components to it mainly. There should be let me find the writing assignment.
How about the exam?
No, let's not open that one up. Let's not do that. Anyway. Very sly, though. Very sly. I didn't get a lot of sleep either. You almost got me, though. Anyway, so you have 2 prescriptions, and basically these are going to be the kind of assignments you're doing for pharm, basically from here on out. The main point is to get you familiar with writing prescriptions, both inpatient, both outpatient, to get you familiar with it. You will find that by the end of Pharm 2, you're going to be very familiar with this stuff. This will build on Clin Pharm, where you're going to actually be doing more of this actual prescribing, coming up with a treatment regimen, etc., and then you're off to rotations, right? And so we have 2 here. This is just to ease you into the process. These are kind of straightforward, sort of outpatient prescriptions that you're going to be writing here. One's going to be for for Celebrex, which is a pain reliever. You can look up information about that. The next one's going to be amoxicillin suspension, very similar to what we did on the actual the PowerPoint we were just looking at. Okay, so pretty straightforward. I give you all the dosing here already. Let me see here. Actually, for this one, for the first one, you probably want to look this up in Lexicomp. You can go through up to date. Just type in Celebrex, and it'll bring you the drug product information. If you have trouble finding it, let me know. The amoxicillin here, I already give you the dose. You have to go and look up what the concentration is. I'll tell you that if you go and look up the Lexicomp and go through, through up to date, you type in amoxicillin and go to the drug reference. There's a section called dosage forms that will give you all the different ways that the actual drug comes. So there's tablets, or the liquids, or whatever. In terms of concentration, I will tell you that more concentrated is better. Right here, I mentioned using the 400 milligram per 5 ml is what I want you to use, and that will again help you out and kind of figure out what your dosing should be. Okay. Now the question is, well, how are you being graded on this thing? What kind of things am I looking for? This is where the rubric comes into play here. This is basically your guide towards writing these prescription assignments. Let's see. So here's an example prescription of what this is going to look like. Okay, so basically kind of go through the details here. The things I'm actually going to be grading you for, and again, this has to be handwritten. Why do I want you to handwrite this? Torture. Make sure you can write legibly, perhaps. In a lot of places, you may think, well, I'm just always going to use a computer. Not necessarily, right? Some offices that still use paper scripts. You're going to find that it also helps to train that muscle memory and remembering what do I need to include on this prescription to make it valid, right, from a legal sense. And so that's why I have you write it. Also, I had one instance where I was working with this peds emergency medicine doc who had just graduated from fellowship maybe 6 months before, and we had a downtime, right? Normally, the prescription would be generated through our computer system, would just print out and you're good to go. They just had to sign it. This night the computers decided to go down out of the blue, and she said, "Oh, I need to write a prescription for this patient." I said, "Okay, well, here's the prescription pad. Go ahead." And she goes, "I don't know how to write a prescription." And I said, "What?" And she's like, "I never had to do it." And I said, "Oh, interesting. Here's how you do it." And they said I went through kind of what I do with you guys. So because I never want to be able to say that one of my students has never written a prescription before, so I make you write a ton of them. So you'll have 2 to write to start with. Basically going through, and this is the stuff you're going to lose points on if you do not include it, right? There's certain style things I don't really take a ton of points off for as long as it's still technically correct. But notice here that if you're missing anything, easy points off. So just make sure you go through, make sure everything is present there, right? So things like name and address of the provider, patient name, date of birth. If you want to be cute and make up your own provider name, that's fine, whatever. If you want to put yourself, whatever, I don't really care. Sometimes it makes it a little more entertaining if it's something like interesting or funny. But basically make sure you're going through writing out the medication name and strength. The instructions for use, this is where you're going to get the most of the points for the prescription, because I want you to see how much to take, how often to take it, what route is going to be the administration route, the indication, and then also if it's a PRN medication, PRN just means what? As needed, meaning you need to make sure you include that. If it's as needed for something, include what it's as needed for, right? Maybe obvious in some cases, maybe not so obvious in others, which is why I want you to write it. The dispense quantity is really important. So how much does that patient need to fulfill the script you're writing for? Any refills they need to have there, date written, and then the signature with the credentials, right? So if you're writing for House MD, I better see an MD there. If you're writing for yourself, I better see PAS1, whatever the case may be, okay? Credentials need to be there. And again, you can see all these are being met in this example prescription here. Okay, very straightforward. To do so, I would like you to write it on this blank page here. To turn it in, simply print this out, handwrite it, scan it in with any camera app or whatever. Use your camera, convert it over into PDF, whatever you got to do, and upload that through Canvas. Okay, pretty straightforward. If you have any issues, let me know. Any questions on that so far? Okay. Let's see. Any other questions? Everyone's good? Okay, let's see here. Would you want patients to round to the nearest ml when taking liquid suspension medications? What do you think? Nearest ml? If you're able to go a little bit more specific and get to maybe like the 10th of an ml, if the dosing syringe allows for that, I say go for that. You typically don't want to go beyond a 10th of an ml. It's a little bit too specific. If it's within 10%, you round to an ml, whole number, that's totally fine as well. If the dose came out to be 9.8 mLs and you round it up to 10, I'm not going to count off points for that. Okay. If it was something that is, a very narrow therapeutic index drug, and it was IV preparation, it was very concentrated, that may be a little bit more dicey, but we'll come across those situations on a kind of piece by piece basis. But typically, round to a whole number within 10% is typically okay. Okay. And then I'm going to say this to the end. I'll get back to that later because I want to make sure I cover all my material. Aha, your tangent did not work this time. Anyway.
Foiled again.
Foiled again. Is it you? Are you the one? No. Oh, no. The identity's been exposed. Okay, so moving on. Now we're going to kind of switch gears a little bit and talk about therapeutic drug monitoring. What is therapeutic drug monitoring? We monitor drugs therapeutically. Basically, yes. It's how we're taking blood samples from a patient, looking at the level of the drug in the serum, and then equating that back to, is this a toxic dose, is it a therapeutic dose, or is it a subtherapeutic dose? Is this fitting within the range, that Goldilocks range where it's not too much, not too little, but it's just right for your patient, okay? Now, in terms of definitions here, I want you to know peaks and troughs. Peak is what? The highest concentration is going to get after a dose. If you're looking here at this one, let's see, where am I? If you're looking here, this would be the peak after, say, for instance, an IV administration of a drug. Down here, you're going to see the trough is what? The lowest level before the next dose. Now, is that always going to be 0? Why not? Remember steady state? Remember we talked about how you have an average concentration? You're putting in more drug before your body gets rid of all of it in a lot of cases, such that you have this nice sort of sine wave sort of pattern here, right? We're just going to have these peaks and troughs that should generally not be getting to 0, because what happens if the patient misses the dose? That's when you see that increased metabolism and you find it goes down to close to 0, right? But again, by giving it at a normal rate interval, half an hour, every 12 hours, every 24 hours, whatever the case may be, you should find that a peak and trough sort of pattern should be set up. Now, it should not change unless something in terms of the dose changes, the interval changes, or the patient's perhaps clearance changes, things like that, right? Okay, and remember, we can dose drugs wildly differently, and the main difference is that, we could do it where you're giving a very large dose very infrequently, or we could do a smaller dose more frequently. What were the problems with using the larger doses less frequently? The vacillation between the peaks and the troughs you see here are much wider, so what does that mean in terms of toxicity and efficacy? You're more likely to get high levels, meaning you could see toxicity there, and then also you're more likely to get low levels where you may see lack of efficacy. So by some drugs, this is not a big deal. You can get away with that. Other drugs, it is more important that you do not do that. And so we may give smaller doses more frequently in order to keep that change between the peaks and the troughs smaller, right? That way it's the same average steady state concentration, but you just keep that sine wave, you're going to keep it a little bit smaller, okay? That make sense so far? Okay. And again, steady state takes about how long to reach? 4 to 5 half-lives. Remember, depending on the drug, that could take anywhere from, say, a minute, 24 hours, could take a year potentially, right? How do we get around that weight to get to steady state? Our loading doses are the thing that helps us out with that, right? Could we give a big bolus dose up front to get them up to steady state initially, and then use maintenance dosing to keep them there?
That's the first term used in that bolus, but I guess.
Yeah, basically a bolus just means one dose, right? It just means one intermittent dose given as kind of over a short period of time typically. So a loading dose is just kind of another term you could use for, say, a bolus dose is not always a loading dose, but a loading dose is always a bolus dose. Make sense? Anyway, so again, by giving a loading dose, that you'll kind of avoid that wait to get to steady state, you'll be already there. Okay, so clinical pharmacokinetics, this is where we're basically applying these terms and all these ideas we had regarding kinetics and applying them to actually managing our patients in terms of making sure that they're getting the right dose, the right amount, the right time interval, or all these different things to make sure they get treated appropriately. We're trying to maximize their efficacy while trying to minimize that toxicity there as best we can. Now remember, some drugs have a very wide therapeutic index, and you think this really applies, this therapeutic drug monitoring applies to those drugs? Not really. If it has a really wide therapeutic index, it's really hard to screw up. And so I don't really care if I have really big peaks and low troughs, because it's probably not going to mean a hill of difference, right? However, if I have something with a narrow therapeutic index, where that ground between therapeutic and toxic effects is very narrow, you may find this is going to be much more important. I'll give you some clinical examples of this in just a little bit. But again, the main point is try to make sure we're minimizing that toxicity while maximizing their efficacy. So again, we're using the serum drug concentrations to help us out with this, and it's important to understand what are the potential benefits of it, to understand what the limitations of drug monitoring is, and then see how we can actually apply it, right? And again, a lot of times we're trying to do some prospective drug dosing beforehand. So if we know a patient has renal failure, I can prospectively determine that, okay, maybe I need to give this drug less frequently. However, once we give that drug, we get those levels back. Now we can sort of reactively change that dose to make sure they're going to be within the right dosing range. Okay. And again, I'll give you some good examples of this. Antibiotics is going to be a big one that we're going to talk about, and you may use this quite frequently if you work in the hospital, especially. But anywho, again, one of the big things we try to do is, one, we have to define what that therapeutic range is, right? You can get a random level of any drug, but if it doesn't correlate to a therapeutic range, it doesn't really help you at all. You don't know, okay, is that a toxic dose? Is it an effective dose? I have no idea, right? So in those cases there, that's what we're trying to establish for some of these drugs, is what is that therapeutic range? And again, remember, we're focusing more on drugs that have that more narrow therapeutic index, something like this, where there's a lot of overlap between the efficacious doses and the toxic doses, versus something maybe a little bit wider there, right? This one has a wider therapeutic index. Okay. And again, depending on how that slope goes, you may find that, you know, the slopes may overlap quite a bit. They may not so much. Obviously, the less overlap you have, the safer the drug is, right? And what happens to that ratio, that therapeutic index ratio, as you get bigger or smaller, the farther away those numbers are, the ratios get much bigger, right? That means safety, right? That means you're going to have a much harder time overdosing someone on a medication if you have a wide therapeutic index. So that ratio between the toxic and the or lethal effects over the effective doses there, right? Okay. Again, any narrow therapeutic index range is just referring to that small margin of errors where you can find that even these efficacious doses will very frequently lead to toxic doses. Okay. Now, in some cases, if you can try to get away from using one of these narrow therapeutic index drugs and use something more safe, that's always going to be beneficial. However, that may not always be the case. It may not always be a good option, depending on the situation. I can cover some of those as we go forward. But basically, when you're doing this, some of the things you want to look for is, one, you want to see that, okay, I'm given a given drug dose, right? We know there's going to be some pharmacokinetic variability in our patients, and this is frequently the thing that's going to be most variable, depending on renal function, hepatic function, absorption, their distribution. All these things can really range in your patients. That should result in some sort of concentration of the drug at the effect site. So, for instance, if it's an antiarrhythmic, it should correlate to some concentration where? Antiarrhythmic means treat arrhythmias in the heart, right? So you want a certain amount of the drug to get to the heart where it can act as an antiarrhythmic, right? And then when you actually correlate those effects to what the patient experiences, this is going to be the pharmacodynamic variability, right? So again, these could be factors where maybe a patient is expressing different types of receptors. Maybe they have a heightened response, maybe a lessened response. Again, that's that pharmacodynamic variability here, right? So patients can kind of waver on either one of those, but the main central point here is that concentration, how we're going to correlate that back to ultimately what effect the patient experiences. And again, there's a lot of reasons for changes in response, right? So there's things like environmental factors, right? I mentioned what happens when you eat charcoal broiled foods. You have CYP interactions, right? You can actually induce some of your CYP enzymes, right? Looking at things like pregnancy, what does pregnancy do? What do you think the volume status of a pregnant patient, what happens to them? It increases quite a bit, right? They put on a lot of extra fluid because, again, they're pumping blood for two people, essentially, right? They get a lot of edema that develops over time, especially towards the end of pregnancy. What do you think it does to the volume of distribution of drugs? It's going to change, right? It increases a lot for especially hydrophilic medications. So all these different things can factor into it, both affecting the pharmacokinetics and also the pharmacodynamics, right? Both of these are the variability in drug response, and some of these things we can try to proactively account for. If I know I have a pregnant patient, if I know I have someone with renal failure, if I know I have someone who just went to a barbecue, maybe I can dose differently beforehand. But then once I see how the patient actually reacts to it and what kind of serum levels I get, then I'm sort of reactively changing those at that point. And that's that therapeutic drug monitoring we're talking about. Okay. So some important considerations. One, this applies to a small, narrow number of drugs. However, some of these are going to be pretty high volume sort of drugs you may be dealing with on a day-to-day basis. So if you work in the ICU, if you work on the med-surg floor, if you work in the surgery, if you work really any of these places, inpatient, you may be dealing with these on a regular basis, right? So say, for instance, you work in cardiology, you may be working with these drugs. If you work in oncology, you'll be working with these drugs. There's a lot of different places, even though it applies just to a narrow subset of drugs here, okay? Now, a lot of drugs we don't necessarily need to measure serum levels for to determine how effective they are. So for instance, if I give someone who is hypertensive an antihypertensive, how do I monitor for the drug effect? I measure their blood pressure, right? It's as simple as that. Do I need to measure the blood level of the drug if the patient's still hypertensive? I don't really need to because I know the drug's not working, right? I know, assuming they're taking it like they should be, I know it's not working. Things like serum cholesterol, right? I can determine How's their cholesterol doing? Are they taking their medications? Is it being effective? I can just look at that. There's no need to actually get a blood level for that drug. And what you'll find is a lot of drugs, you can get a level for any drug really, but it may not correlate to that therapeutic window. If you don't know what that is, it doesn't really do a whole lot of good. Okay. Some drugs have other surrogate markers you can look at. So as an example, warfarin, we mentioned warfarin does what? The blood thinner, right? It's an anticoagulant. Now, we measure that, we monitor that, and you guys have covered your coagulation assays, right, in Clin Lab? Yep. So in that case there, you would know that certain drugs can affect different parameters there. So as an example, if I'm giving someone the drug heparin, which is an anticoagulant, I monitor APTT. You also learn that for warfarin, you measure PTINR. For other anticoagulants, you can't monitor either of those. And so in those cases there, by knowing which ones you can monitor, that is how you establish your therapeutic window. So as an example, someone with a PTINR on warfarin, for a therapeutic effect, it should be an INR of 2 to 3. What's a normal INR? It should be 1, right? Because it's a ratio. Normal person should have an INR of 1. For therapy, they should be 2 to 3. And again, you don't have to do a blood level of warfarin to know if they're therapeutic. I just look at the INR. Okay, so TDM does not really kind of fall within that purview there. So other things as well. When you're doing this, make sure you're looking at you're measuring the drug concentration. Make sure it actually gives you an opportunity to individualize that dose. If it's something that only comes in one fixed dose and you can't really change that, that's not really going to be a good option for you there. And then again, looking at this, you're assuming that the drug concentration is a better predictor of response than the actual dose that you're administering itself. Right? These are assumptions we're making when doing therapeutic drug monitoring. And then finally, there should be a good relationship between the concentration and that pharmacological response. If there's really no correlation between the two there, then it doesn't really help us out. We can't really do that good serum drug monitoring. As an example, like antidepressants, right? So we can have patients with wildly different levels of antidepressants in their system, and they may have wildly different experiences in terms of how efficacious it is for treating their depression or their anxiety. So in those cases, they're not really great for a TDM. So looking at this, if you remember that the kind of total exposure of your patients to their medications is going to be based off of their bioavailability of the drug, right? So that just means what? Which gets into the system, clearance, which is how quickly it's getting out of the system. And these are things the clinician does not control, right? I can't necessarily change the clearance of my patient. I can put them on maybe dialysis and I can help it out, but rarely is this going to be the case here. However, the clinician does control the dose and the interval here. So when you get a level back for a drug, say you're dosing an antibiotic for your patient, you get that level back, these are the things you can do, right? I can't just like look at my patient and say, clear this faster. You're holding on to too much drug. They're going to say, I don't know how to do that. Maybe they're like a ninja and they can like control their breath with or their heartbeat with just their mind. Maybe they can do that with their kidneys. I don't know. But most patients cannot do that. However, the clinician does control what kind of dose you're giving and also how often you're giving that drug. Okay, so that's definitely within our purview there. So as I mentioned, the therapeutic range is not absolute, right? So one thing you've hopefully learned in Clin Lab Med is that the normal range, is that normal for every single person? No, there's always outliers, right? People will fall outside of that. Sometimes you have people who are just snowflakes, so to speak. They fall outside of that range there. And so these are just based on probabilities, right? When they did the studies, they found that patients that fell within this range were most likely to be therapeutic without having toxic effects or have minimal toxic effects. So just because a patient is sitting maybe at a sub-therapeutic level, at a low level, but they're having no problems, they're having good efficacy, does that mean you need to go and change that dose? No. If they have a high level, a supra-therapeutic level, and they're not having any toxicity and the drug's working well for them, do you need to change that dose? No, right? Again, what's the mantra? Treat the patient, not the number, right? So treat the patient, not the number in these cases here. So be wary of that. Just because the number is abnormal does not mean you need to act on that. Technically, an INR of 2 is abnormal for a person who's not on warfarin. So reads is abnormal on the labs. But if you know your patient's on warfarin, that's not abnormal. That's good. That means it's therapeutic, right? Anyway. So some additional considerations here. Typically, when they figured out these ranges, it was probably in a pretty small population. So you have to consider where the study was done in the first place. You may not always have access to that, but consider, that populations change over time. If a therapeutic range was defined back, say, in the 1950s versus the 2019s, you may find that the population has changed, and that may change the reference ranges as time goes on in some cases there. Now, oftentimes it's kind of hard to determine the validity of some of these published ranges. A lot of times it's hard to find. Sometimes you find things just turn into medical dogma, where it's like, well, how do we come up with that range? And people are like, I don't know, it's just how I got trained. And you go to that person that trained them, and you say, well, how did you come up with that number? And they say, I don't know, it's how I got trained. And so on and so forth, right? So some of these things you may not know why we do it, it's just what we do. which is not always the best answer. Students don't like that answer, as it turns out. Okay, so typically we are shooting for a one particular level when you're dosing these medications here. So if you have maybe a therapeutic range of say 10 to 20, I don't want to shoot just for anything within 10 to 20. Try to shoot for middle of the road typically. So let's say, okay, let's shoot for 15, right? Or if the level I'm looking for is 20 to 30, let's go shoot for 25, right? Just kind of go down the middle there in most cases there. And starting off, you can assume most patients are going to behave like an average member of the population, right? So unless you know they have some disease state or something that predisposes them to having some alteration here, you can assume that it's just a normal individual that should be acting like most other individuals there. Because again, when you look up drugs in say Lexicomp or other drug references, you're going to find that they will list population pharmacokinetics. So if it says the volume distribution is 0.6 liters per kilogram, that's for the general population. Now, do people fall outside of that? All the time, right? Because it's an average. It's not saying that every single person is 0.6, but most people are pretty close to it, okay? Don't worry, you get to talk about averages and medians and all the fun stuff in EpiBio next semester. I'm really cooking up some good stuff for you guys there. Anyone like a stats expert? Okay, I need to find one of those before I start the class then. Just kidding. So assume they're acting like an average member of the population. And again, we're using these average PK parameters, pharmacokinetic parameters there, right? And then from that, we'll basically calculate their dosage regimen. So we'll figure out what their clearance should be, how they're clearing the drug, what their bioavailability should be, etc. And then we'll use that to help us come up with a dose, both the dose of the drug and also the frequency that we're going to administer that drug. So starting off with, again, imagine if we get a drug level coming back. Remember, how long until we get to steady state? 4 to 5 half-lives. It's important to know what the half-life is for the drug you're dealing with, because what happens if you were to draw a level too early? And again, you're going to force me to draw again, which is never good, but let's just say we're dosing our patient here, right? So we have a concentration on the y-axis, time on the x-axis here. Remember, as you give a drug, you're going to see this kind of sine wave sort of things here. But again, it's going to take time before you really get to steady state, right? What happens if I draw a level too early? It's going to look falsely low or falsely high? Falsely low. So what is your inclination if you see a low level come back? Increase the dose, right? So what does that do to your steady state at that point? If you go back, increasing your dose increases your steady state, right? Once you hit that new steady state level. So now the patient may be super therapeutic when you accidentally dose too early. And this is a very frequent mistake that we see people perform, is they will dose, or they'll try to get a level off of medication after maybe one administration, and it definitely was not 4 to 5 half-lives, and they do it too early, and then they readjust the dose, they react to that number instead of reacting to the patient, and they overshoot it, okay? Common thing we run into. Now, one scenario could be the level comes back and they're having good adequate response, level looks good, you say, okay, let's go ahead and continue treatment. Well, oftentimes this scenario is going to happen where the patient's either having a subtherapeutic response, maybe their infection is not clearing, their fever is not going down, their white count's not going down, or they may be having toxicity, maybe they're having renal issues, maybe they're having blood pressure issues, etc. At this point, you can manipulate either the dose or the interval. I will tell you in general, it's a good idea just to do one or the other. If you do both, you tend to either over or undershoot your dosing in a lot of cases there. So just as a good rule of thumb, just do one or the other in most cases. So reasons why we would use our drug concentrations here. So one, if it helps us to provide any kind of additional information in conjunction with other data to help determine the patient's status, right? So if we're looking at things like renal function, hepatic function, looking at drug levels, looking at any kind of toxicity they're experiencing, you're kind of correlating all these things into one cohesive picture, right? It's part of that treating the patient, just not the number there. And again, this is going to provide that basis to come up with an individualized dose. So that way you could have a whole room full of people on vancomycin, which is an antibiotic we do TDM for, and they may all be on very different doses, even though they may be similarly sized patients. And so one of the big things you want to do as well is that we want to see, are the kinetics really changing in these patients based off of any changes in their pharmacokinetics, right? So again, looking at the patient's status, imagine if you have a patient who is, say, getting admitted for sepsis into the ICU, and they're developing hypotension, and then that hurts their renal function. You have to go back through and assess, okay, well, is my drug level going to be increased because of this? These are things we want to think about. Also look about maybe if we add on a new drug, maybe that has an interaction, or new food into their diet, or new herbal into their regimen, may see that can also affect the levels additionally, right? So looking for changes in pharmacokinetics is a good idea why you might want to draw a level. And of course, we can always check for adherence, right? So oftentimes you have patients who are maybe pain management patients, right? And I remember when I was in rotations, I saw this, and they were doing a drug screen for a patient who was on oxycodone to see if they tested positive for oxycodone. I was like, well, they have chronic pain. Of course they're going to test positive for oxycodone. Is that always the case? Why would it not be the case? I heard it. I whispered it. They could sell it. They could sell their medication for, they're really into crack cocaine instead. They can sell it for that, right? So they would test for adherence. They'd actually do urine drug screens to make sure patients were taking their doses like they should, right? Did I tell you about the old vet who had coming in the scooter? All right, so my wife, she's a pharmacist as well. She did her pain management residency at the VA in Gainesville. And so she had, one of her rotations was in the pain management clinic there. And so there's this one guy who would always come on this little motorized scooter, right? Come rolling in. And every single week, he'd roll in for his medications. He'd have this lady on his lap. And this lady was just drop dead gorgeous, always had the nicest clothes on, nicest jewelry, great makeup, everything looking great. You know, this guy come in, get his medicine, leave with the lady. Come in, get his medication next week, leave with the lady. All of a sudden, when his drug test didn't go so well, and they refused to give him any more of his medications, guess what happened to the lady? She disappeared too. Very sad. Very sad for that guy. Anywho, point being though, is that patients may not be taking their medications like they should, sometimes for legitimate reasons, sometimes for illegitimate reasons. But you can test for adherence for these things. So if I have a patient who is on warfarin, and they come in, their INR is 1, that may be indicative that they're not taking their drug like they should be, right? Their adherence is low, so their INR is going to be closer to what normal would be, right? So little things to think about. Okay. So common reasons that you may request a drug concentration. So imagine if you're having a patient experiencing toxicity, you may want to draw a level to see if maybe the level is too high to explain that toxicity, right? Maybe they're having a lack of therapeutic response. You know, you have a patient who you're giving an anti-seizure medication to, but they're still having seizures. Well, it could be because maybe that seizure is just not treated with that one particular drug by itself, or maybe the level's too low. By adjusting that dose, maybe you get better efficacy out of it. Okay, I mentioned the adherence thing to check for as well. If you want to check for any changes in dosing regimen, it's a good idea anytime you change the dose to go back and check a level. Maybe the clinical status of the patient has changed. Maybe their renal function has gone down. Maybe hepatic function has changed, things like that. Or if you're checking for potential drug interactions, it's another good reason to go ahead and look at a level. So some information you need in order to properly sort of interpret these serum drug levels. And this is where it's always a good idea, you know, when you work in a hospital or anywhere you work, it's a good idea to be friends with several people in that environment, right? So like your environmental cleanup people, be friends with them. Because next time you have a big mess, you want them to come help you out, right? Your nursing crew, never ever make a nurse mad if you can help it. Because they'll make your life just terrible, just bad. Also, your lab techs, like be really good friends with them because you can call them up and ask them information about this stuff and they can help you out, right? So things you want to know about when you're trying to interpret one of these drug concentrations. Oh, it goes without saying, be friends with your pharmacist as well. They will also help you. The only people you shouldn't be nice to is actually be nice to everyone, right? This is a general good rule. Don't be a jerk. Anyway, so time the blood sample is taken. Why do you care about the time it was taken? Okay, good, yeah, because I want to know, is this a peak level? Is this a trough level? So I know what time the drug was taken. What else do I need to know? The last time the drug was given, right? I want to know the relationship between when that level was taken versus when the dose was given to see, is that a peak level? Is it a trough level? What is that, right? So then I can kind of know, okay, where are they at within the cycle of getting that dose? Because it may tell me some information, right? You want to know the dosage regimen, so how often they're getting it. So that way I know if it's a 12-hour trough or an 8-hour trough, like that can also be useful information to see, you know, because obviously the level's too high at an 8-hour trough. Maybe I need to change it to give the drug every 12 hours. Maybe that would be more appropriate for them, right? You want to know the patient demographics, right? So you need to know their age. You want to know their lab values. You want to know if their renal function is any good. You want to know about their hepatic function, things like that. You want to know about concurrent medications. Obviously, look for any interactions that could be playing a role there. Also, the reason why you're monitoring, so like why did you get a level? Now, and do you think in your clinical practice, every level that you order, you're going to be the one to actually evaluate it? Very frequently, no. You may actually find you may be the one coming on to shift. Someone else ordered that level, and then all of a sudden it comes back, and the nurse is calling and say, hey, you got this abnormal level. What do you want to do with it? And you're like, I don't even know why they got the level in the first place. That can be a really tough position to be in, right? So you need to make sure that you document these things. Hey, why am I actually checking this level? That's why your documentation in your notes is so important, right? Hey, I'm going to get a level for vancomycin because I'm worried about it not being therapeutic, right? Things like that. And then what is that desired range you're shooting for? Sometimes drugs will have different ranges depending on what the indication is. So for instance, vancomycin, I mentioned, is an antibiotic we use for pretty serious infections. And you're going to find that for, say, something simple like maybe a cellulitis, I can shoot for, say, a range of, say, 10 to 15 versus micrograms per ml. If I have something like meningitis, right, where's that infection at? It's in the CNS, right? It's more difficult to get drugs to penetrate the CNS because they have that blood-brain barrier. So I have to give a higher level of the drug to get to the site of action. So in those cases, I may be shooting for, say, 15 to 20. So by knowing what the indication is, you also know what kind of range you're shooting for. Okay, these are important information to know when you're trying to interpret that level. Okay, so some pretty common characteristics you're going to find with these drugs here. You're going to find that, again, there is no real observable therapeutic or toxic endpoint, right? Again, it's always going to be sort of on this gray spectrum here, where, again, patients may manifest toxicity at therapeutic levels. Patients may manifest, therapeutic effects at sub-therapeutic levels. Okay. Yeah, so it just depends on the drug and how the patients are reacting together. Again, the concentration you're taking is a surrogate for the actual site of action. So for instance, if I'm giving vancomycin for meningitis, I'm not measuring CNS levels of vancomycin, I'm measuring a blood level, right? That's a surrogate for what should be at the CNS at that point, so I shoot for the higher level there. So again, these are just surrogates here. And again, these are going to be narrow therapeutic drugs. They're going to have pretty variable pharmacokinetics. So depending on their organ function, you're going to find that the kinetics can change pretty wildly. Again, they should also have some risk associated with them. So if you're doing therapeutic drug monitoring, it's because you have a pretty good reason to. So one, toxicity could be a big issue, or that lack of responsiveness or how effective could be detrimental to your patient, right? If you're giving it for a certain type of infection, you want to make sure you clear that infection. Otherwise, you're going to have some issues, right? And then typically they'll have some pretty stable pharmacologic effect. Again, it shouldn't have a lot of variability in how well the drug works once you get up to that therapeutic range. Okay, the assay you should be shooting for should be accurate, hopefully, precise and specific, and hopefully it's not going to be too bad of a turnaround time. So when I say turnaround time, what does that mean? How long it takes from getting the blood out of the patient, getting it to the lab, to getting it back to you as a provider to evaluate it, right? So how long does that take normally, you think? Depends. Depends on, does the lab get performed in your lab in-house? Do you have to go out to Quest Diagnostics whenever the patient can make it out there to actually get a level? Do I have to send it out to somewhere like Mayo Clinic to get the level done? It can vary depending on what you're doing. Run-of-the-mill stuff, you can get in the hospital, maybe turnaround time, maybe 45 minutes an hour. Then the lab calls you up and says, oh, lab's down. We'll be up maybe like 2 hours, hopefully. Right, so you can see the turnaround time can be very impactful there. Docs will call me up when I'm on call for the poison center and say, hey, I want to check a level for this drug. And I was like, well, that's a drug that no one does levels for. You can send it off to Mayo Clinic, but that level's not going to come back for 2 weeks. Your patient will have either gotten better or not by that time, so the level's not really going to help you, right? Things like that you have to consider turnaround time. A good example of this actually is to go back to the tox stuff, patients who ingest radiator fluid or windshield washer fluid, right? They're called toxic alcohols. They can be very, very deadly, right? In the course of maybe a day or two. Up in north, where it gets colder, you have a lot more exposures to that, right? A lot more people are drinking that stuff on accident. You kids get into it. People drinking on purpose or suicidal purposes, etc. But up north, they do it all the time because, again, it gets colder up there. They have more access to it. So they are able to do it in their hospitals very easily. They get turnaround time of maybe 30 minutes or so. Down here in Florida, where it's exceptionally hot, we don't have a whole lot of issues with people drinking too much radiator fluid. That means that we don't do those labs routinely. It just doesn't make financial sense to do that in the house. So at that point, what do we have to do? Well, I can get a level and I can send it off to Mayo Clinic to run it. But again, it's going to take like a week to come back. That patient will either have died or gotten better by that point and doesn't help me out at all as a clinician. So turnaround time is super, super important for some of these labs. And you get to understand whether it's something that's routinely done or something that's like a special order kind of thing there. And hopefully, your lab's going to be relatively inexpensive. Some of these can be very, very expensive depending on the case. So commonly used drugs that we do therapeutic drug monitoring for, anti-infectives, right? So things like vancomycin, aminoglycosides like tobramycin and gentamicin, we do this all the time on. Now, most of the time, if you talk to like Professor Kaplan, who works for a hospitalist group, he writes for, it says vancomycin, pharmacy to dose, and he forgets all about it. He doesn't think about it. So that's really nice. He gets to do that, right? You might be able to do that too one day. However, depending on where you work, you may not have a handy pharmacist there 24/7, and then you have to be the one to dose it. So again, it's good to know this kind of stuff, know what kind of levels you're looking for, know how to do this. And that's what we're going to talk about. We'll get into the specific drugs later on and how we look for those levels. We'll talk about that in Pharm 1 and Pharm 2. Don't you worry about that. We'll get to it. I just want to give you some examples of things we're going to do, right? Cardiovascular drugs like digoxin, right? Anything that is an antiarrhythmic that can treat arrhythmias, guess what it can also cause? Arrhythmias, right? So these are inherently narrow therapeutic index drugs you have to monitor levels for. Antiepileptics, anything that can treat a seizure can also cause a seizure, right? So again, these are levels you have to look at and make sure they're not getting too high or too low. And then also things like immunosuppressive agents, right? What do these do? Suppress your immune system. Why would we want to do that? If you have like a transplant or something, right, and you don't want to reject that foreign tissue that someone has just now put into you, right? Maybe you have a new liver or kidney that you don't want to, your body to reject because it looks like foreign material. That's where your immunosuppressants actually come in and can help to prevent some of that. Those are narrow therapeutic index drugs because what happens if you suppress the immune system too much? You get a fungal infection, viral infection, bacterial infection, you can die from that, right? So again, this is why we monitor these levels, because inherently, if they get toxic, they can be really, really dangerous potentially. So what are some limitations here? Obviously, cost is a big thing. One of the big things that we do as part of the pharmacy service is try to make sure we don't get levels kind of just willy-nilly and just get them all the time, because costs tend to add up for that sort of thing there. We also don't want to do this for drugs with wide therapeutic ranges because, again, clinically it doesn't really matter. If you get the level a little higher, a little lower, it's not going to make really that much of a difference for your patient there. Okay. Other things, like if you don't have a good relationship between concentration and response, it doesn't really help you out at all. Some of my neurologists will be ordering levels for drugs like just random, anti-epileptics. I'm like, there's no therapeutic range for that. Like, what are you gonna do with the level? They're like, I don't know, it just makes me feel better. Oh, okay, you can do that. Not the most economical thing, but okay. Other things, if there's no reference data available, so again, if we just don't know what that correlation is important. And then also if there's direct response measures. So as an example, if it's something for your blood pressure, I can just measure your blood pressure. That's easy. What about for something like a seizure medication? Like, how do you tell how efficacious it is? Presumably your patient didn't have any seizures, but what if they went long periods of time between seizures in the first place? How do you know? You monitor, but it could be months before they have another seizure. You don't know, is it because the drug's working, or is it just because they wouldn't have had a seizure in the first place? How do you know? I have this can of elephant repellent up here. It works really good. You haven't seen a single elephant, have you? Probably likely that no elephants would have shown up anyway. So the question is, that's why we do some of this monitoring here to make sure, okay, well, they're not having a seizure, let's check the level. If it's therapeutic, that maybe lend us to more think that, okay, well, it's probably maybe because the drug is around, not because they wouldn't have had a seizure otherwise. So again, sometimes a little dicey. Okay, so some inappropriate uses for drug concentrations. If it's obtained routinely or too often, don't check a level just because it's been a couple of days. Like, you need to have a good indication to do so rather than just routine. Are the concentrations for the patients responding appropriately? If you're looking at it and it appears that, the patient has had no physiologic changes and the concentration is fine the last time, it may not be a good indication to go ahead and get one now unless you feel like something has changed in that period of time there. Again, if you're getting it, even though it doesn't look like anything's changed for the patient in terms of kinetics or dynamics. And then also samples taken at the incorrect time. So why do you think a sample will be taken at the wrong time? It happens all the time, right? So again, if you don't have good communication with your nurses, you may find and tell them, hey, I want you to get the drug before this dose. I want you to get it before the 4th dose of this medication. And they miscommunicate, and then all of a sudden they get it before the 3rd dose, maybe before steady state's been hit. Again, that leads you to make an incorrect conclusion about how to change that dose of the drug there. Or for instance, if you're trying to get a trough of a drug right before the next dose is given, but the nurse forgets and they give the drug and then get the level, what is it now? Well, it's like a peak level. And if sudden, if you don't look at when the drug was given versus when the level was taken, you may falsely assume it's a trough level, and all of a sudden you're like, whoa, this drug is way too high. You gotta do something about this, when really it was just a peak level, right? I've had nurses who had drawn levels out of IV lines that had the drug infusing through it. So like the level is like 10 times higher than what it should be, and I'm like, well, that looks way wrong. Is the patient alive? Yeah, the patient's doing fine. Okay, it's probably right. Go back to the nurse and say, hey, what are you doing? You're like, oh, yeah, I drew it out of this line. Okay, that makes more sense, right? Again, I say nurses a lot, but mainly because they're the ones at the bedside doing the majority of the legwork. They're amazing people and they do really good work there, but these are some of the inherent issues that can come up. And again, you need to be the ones to make the interpretations, right? So look at when doses were given, look at when times were taken, things like that. But of course, documentation is huge, right? So if the nurse documents something incorrectly, they forget something, etc., then it can make this more difficult, right? So anyway, the benefits of TDM, why we like to do this is, one, it helps to reduce the number of patients encountering that toxicity, right? So again, if we can head off high levels early and try to reduce that dose or change that interval, that's going to be useful there. And then again, more patients will have those concentrations within that therapeutic range. In some cases, you actually find you get better clear rate for infections. You get patients out of the hospital sooner, things like that. And again, this is in comparison to patients that have just had straight dosing without the benefit of using therapeutic drug monitoring. And we find better effectiveness of these drugs, reduced toxicity, decreased length of stay, more cost effective overall. Again, so a lot of benefits to doing this if it's appropriate for that individual drug. Okay, so I think, how much time do I have left? 5 minutes. That's not enough to get through all the steps of TDM, so I'm going to stop here. Is there any questions in the meantime? No? Do you have any classes after me? Okay, so I'm just going to go to 4 anyway. I'm just kidding. Just kidding. I'm not going to do that to you. It's too rude. Let me check the sticky board real quick. Any other questions? Nothing at all. So let me see here. The most interesting OD I've seen in peds or in general, I don't know about peds specifically. I have an interesting one though, at least. You guys ever heard of triple C's? Triple C's stands for cortisone, cough, and cold. Are you trying to demonstrate for the? So it's something called cortisone, cough, and cold. It's a medication. It's an over-the-counter cough and cold medication, as the name implies. That would use. It was good for patients with high blood pressure because it didn't have any medications that would increase blood pressure, right? So anyway, but children, adolescents would abuse the drug in order to get a high from it. One of the drugs included with it was an anticholinergic. It's called chlorpheniramine and histamine as well. But basically, you can get really high off the stuff if you were to take too much of it, just like Benadryl can do the same thing, doxylamine, etc. This is not for your purposes to go try at all. Again, this is a very dumb thing to do. But anyway. But essentially, when you were to get a box of this stuff, you'd bring it out and be like in a little plate, like a little aluminum, like a plastic plate, and you just pop out the pills, right? You've probably seen those before. And so they would do them their dose would be in terms of the number of plates that they took. Take one plate, it's probably like 15 pills or something like that, right? Do 2 plates, like 30. So you can see where this is going. So there's a party. And it was going on, and there's several adolescents there. And that's the thing with over-the-counter meds is that usually these adolescents have more time than they have sense, and so they go with things that are easy to get a hold of, and you can go to Walgreens and buy a ton of this stuff, no problem, right? So anyways, they bought a bunch of this stuff. Kids are doing it. This one guy tried it, and it was his first time doing it, and he says, well, I should probably go for the gusto. I'm going to do 2 plates. It's not well advised. So the guy got very, very toxic from that. He developed what we call anticholinergic toxidrome, where he was very near to having seizures, didn't quite get there. But anyway, he was just very having a lot of hallucinations. He was very tachycardic. He was just very out of it. They called 911, brought him in. Just to give an example of the doses of drugs we had to give him, normally we give them a benzo, right? Something like an Ativan or something to try to calm them down. A normal dose of Ativan I would use to treat a seizure is 2 milligrams. Okay, this kid, just to get him to sleep, to chill out enough where you fall asleep, 14 milligrams. Huge amount, incredible amount of the drugs you have to use just to calm this guy down. And so fortunately he recovered. He did well once he metabolized the drug off. But that was one of the more interesting ones I saw. I have more I can tell you later, but you don't have time for that.